Welcome back to another deep dive. It's great to have you with us again today.
Yeah, glad to be here.
Whether you are prepping for a meeting, trying to catch up on global health trends, or you're just, insanely curious about how massive systemic problems get solved, we have an incredibly pertinent set of sources to look at today.
We really do.
We take a stack of data, reports, studies, articles, and we extract the vital insights so you can stay well-informed without having to read through hundreds of pages of institutional literature.
Exactly. And today's material is, it's a bit of a heavy hitter.
It is. Today we are analyzing a critical global health update published by the World Health Organization on March 3, 2026. The entire focus of this release is childhood hearing loss.
And this specific update is it's a remarkable document. It takes a pervasive, often overlooked global health issue and maps out a highly pragmatic, decentralized framework for addressing it. The implications stretch far beyond primary care. We are talking about touching on global education metrics, long-term economic forecasting, and community-level technology adoption.
So our mission for this deep dive is to unpack why nearly 100 million children globally are navigating what the data describes as a silent crisis. We're going to look at the structural failures allowing this to happen.
The blind spots, essentially.
Right, the blind spots.
Yeah.
And more importantly, how the WHO proposes shifting the front line of healthcare away from specialized hospitals and directly into everyday environments. Specifically, local schoolrooms and the smartphones already sitting in people's pockets.
Yeah.
Okay, let's unpack this, because the sheer statistical scale of this issue requires some immediate context.
It really does. The top-line data from the WHO update sets the baseline here. Globally, over 95 million children and adolescents between the ages of 5 and 19 are currently living with unaddressed hearing loss.
95 million.
95 million. We're looking at a demographic cohort roughly the size of the entire population of Vietnam.
Yeah.
All moving through their critical developmental and educational years without access to necessary auditory care.
Which brings us to the underlying research. The update doesn't just, pull these numbers out of thin air. It leans heavily on recent data from the Global Burden of Disease study.
What's fascinating here is how the global burden of disease methodology highlights the deep inequities in global health.
For those unfamiliar with it, how does that work?
Right. So the GBD study is a massive, ongoing epidemiological effort. It doesn't just count who is sick. It quantifies health loss across hundreds of diseases by age, sex, and geography.
Okay.
It calculates what we call DELI-wise, disability-adjusted life years. And when you apply that rigorous methodology to childhood hearing loss, the global heat map is incredibly skewed.
I would imagine.
Yeah, the prevalence is disproportionately concentrated in low and middle-income countries. The data specifically points to regions in Africa and Southeast Asia as bearing the vast majority of this burden.
There's a quote from Ms. Devora Kestel, the director of the WHO Department of Non-Communicable Diseases and Mental Health, and it highlights a severe structural failure. She notes that currently, over 80% of the people who require ear and hearing care simply do not receive it.
80%.
But at the same time, the WHO estimates that nearly 60% of ear and hearing problems could be prevented or treated at local health clinics. I have to push back on this paradox.
It is a paradox.
Right. If 60% of these cases can be resolved with basic care, why are 80% of people missing out? Are we looking at a fundamental lack of medical knowledge in these regions, or is this a massive logistical failure?
It is almost entirely logistical and infrastructural. In many of the regions highlighted by the GBD study, primary healthcare systems are oriented heavily toward acute infectious diseases.
Things like malaria.
Malaria, cholera, severe respiratory infections. Audiological care is historically viewed as a specialized tertiary service. So the basic tools needed to treat that 60%.
The treatable cases.
Exactly. Things like otoscopes to check for impaction or simple antibiotics for middle ear infections. Those are either caught up in broken supply chains or the primary care workers simply haven't been mandated or trained to look for auditory issues.
They're just not looking for it.
They aren't. Furthermore, you have to factor in the sheer geographic friction. If a rural family has to travel 2 days to reach a clinic with an audiologist, the economic cost of that journey often supersedes the perceived need for a hearing check.
So what does this all mean? When we look at the clinical and sociological impacts of that geographic and logistical friction, the WHO update outlines a severe trajectory for these 95 million children.
Severe is the right word.
We are moving well beyond the basic mechanics of sound perception here. I want you, the listener, to really imagine trying to learn, socialize, and build a career in a world where a primary mode of communication is muffled or entirely cut off.
The clinical literature on auditory deprivation is quite clear on this. When a child experiences unaddressed hearing loss, their auditory cortex is deprived of consistent input. And because of neuroplasticity, the brain attempts to compensate.
It rewires itself.
Exactly, it reallocates resources, sometimes reassigning auditory processing areas to visual or somatosensory tasks. This cross-modal plasticity means that if you wait too long to intervene, simply turning the volume up later with a hearing aid won't immediately solve the problem.
Because the hardware has changed, so to speak.
The brain has literally rewired itself, and that increases the cognitive load required just to process basic communication.
Which means the child has significantly less cognitive bandwidth left for actual learning and executive function.
Precisely. The WHO points out that this underlying neurological strain cascades outward. It directly correlates with severe delays in speech and language acquisition, which naturally throttles educational attainment.
And socially, it must be isolating.
Incredibly isolating. From a sociological standpoint, the correlation between childhood auditory exclusion and adult depressive disorders is well documented. A child unable to fully interpret social cues or participate in ambient peer socialization frequently experiences profound isolation.
And the economic ripple effects of that isolation are devastating.
Mm-hmm.
Poor educational outcomes mathematically translate to reduced employment prospects.
Yes.
In regions like Southeast Asia and Sub-Saharan Africa, where economic mobility is already challenging, adding a layer of systemic auditory exclusion practically guarantees a lifetime of economic disadvantage. It exacerbates generational poverty.
It absolutely does.
This completely changes the framing from a purely medical issue to a foundational macroeconomic problem.
Which is why the WHO is insisting on a systemic pivot. Prevention of avoidable hearing loss, coupled with early identification, isn't just a medical ideal, it is an economic necessity.
That pivot brings us to the core strategy of this update, which revolves around the theme for the 2026 World Hearing Day. From communities to classrooms, hearing care for all children.
That's the rallying cry.
Right. The WHO is issuing an urgent call to governments and civil society to integrate ear and hearing screening directly into school and community health programs. But I want to play devil's advocate for a moment here.
Go for it.
Taking the screening to where the kids are sounds highly efficient.
Yeah.
But realistically, if a rural school in a low-income country is already struggling with overcrowded classrooms, underfunded facilities, and ensuring basic nutritional needs, how can we expect educators to prioritize and execute audiological screenings? Doesn't this just shift the burden from an overwhelmed medical system to an overwhelmed educational system?
That is the critical friction point of any decentralized public health initiative. If the WHO simply dropped a mandate on teachers to just go do hearing tests, it would absolutely fail.
Right.
The strategy relies entirely on providing structured, low-friction integration. The WHO has released specific technical resources alongside this mandate, most notably the Vision and Hearing Screening for School-Age Children Implementation Handbook.
What does that handbook actually look like in practice? How does it avoid overwhelming the frontline workers?
It creates a highly structured triage system. The goal isn't to turn a teacher into an audiologist.
Obviously.
The goal is to use the school as a primary filtering mechanism. The handbook outlines training for teachers to recognize behavioral markers of hearing loss. Say, a student consistently failing to respond to prompts from behind or demonstrating sudden behavioral withdrawal.
So observation first.
Exactly. Furthermore, it integrates basic screenings into existing school health days. If a child is flagged during a routine check, the handbook provides a clear referral pathway.
So the referral pathway is the safety net.
Exactly. Identifying a problem is functionally useless if the family doesn't know what to do next. The WHO strategy ensures that once a child is flagged at school, they are referred to a community health worker who has been specifically trained using WHO modules to perform basic otoscopic exams.
And that health worker can handle the easy stuff.
Yes. They identify and treat the easily resolvable issues like impacted earwax or a basic infection, which make up a large portion of that 60% of treatable cases we discussed earlier.
If we connect this to the bigger picture, this tiered triage system completely bypasses the tertiary hospital for the majority of patients. Step 1 is the teacher observing or running a basic screen. Step 2 is the community health worker clearing the low-hanging medical fruit. Only the complex sensorineural cases, the ones actually requiring specialized intervention, make it to the regional hospital.
You are creating an incredibly efficient funnel. Dr. Shelley Chadha, the WHO team lead for eye, ear, and oral health, summarizes this beautifully in the update. She states that communities and school settings provide a natural and effective platform to reach children.
You go to where they already are.
Exactly. You don't have to build a new platform. You leverage the existing daily routines of 95 million children.
Let's transition into the actual interventions, because the WHO update provides a really comprehensive toolkit for what happens after a child is accurately diagnosed with permanent or complex hearing loss. It is a fantastic list of cost-effective, evidence-based interventions. We're looking at medicines, surgery, hearing aids, cochlear implants, rehabilitative therapy, sign language instruction, and they also highlight assistive tech like loop systems and captioning.
That's a robust toolkit.
It is, but implementing these in a low-resource setting requires some serious logistical maneuvering. Take a loop system, for example.
Right. An induction loop system is a fantastic example of a highly effective, low-barrier intervention. Functionally, it is a wire that circles a room, like a classroom, and connects to an amplifier.
Okay.
It takes an audio signal, perhaps from a microphone the teacher is wearing, and transmits it directly to a telecoil inside a student's hearing aid via a magnetic field. It completely cuts out background noise and the acoustic degradation of a crowded room.
The challenge, I imagine, is the hardware supply chain. If we are talking about distributing hearing aids and cochlear implants across rural regions in Africa or Southeast Asia, the medical device itself is only half the battle.
Yeah.
You have to account for the maintenance life cycle.
Oh, the life cycle is the hardest part.
Right. Hearing aids require very specific batteries. In a rural setting, sourcing a size 312 zinc air battery on a regular basis is a massive supply chain hurdle. Furthermore, cochlear implants require external processors that are susceptible to humidity, dust, and they require consistent power.
You've highlighted the exact reason why the WHO advocates for strengthening primary healthcare systems as a holistic package. Distributing a hearing aid without a resilient local supply chain for batteries or desiccant dehumidifiers is a wasted intervention.
It just becomes electronic junk in a few months.
Exactly. The WHO guidelines for delivering hearing aid services in low and middle income settings focus heavily on robust, low-maintenance device options. Things like solar-powered charging stations for rechargeable hearing aids and training local technicians in basic device maintenance. The intervention has to match the infrastructural reality of the environment.
Here's where it gets really interesting. When we talk about identifying these issues in a classroom setting, we usually associate audiology with a soundproof booth, a highly specialized clinician, and a bulky audiometer.
That's a traditional model.
But the WHO update details an upcoming technological innovation designed to completely circumvent that requirement. They are launching a free mobile application called WHO Ears, available for iOS and Android, built specifically to support these school and community screening programs.
This is the game changer.
Now, I am curious about the execution here. We have seen countless global health apps fail over the last decade due to poor user adoption, absolute reliance on broadband internet, or complex data privacy issues. What makes the WHO Ears app a viable diagnostic tool in a resource-constrained environment?
The WHO Ears application solves several distinct logistical problems simultaneously through intelligent software design. First, it addresses the need for validated automated audiometry.
Meaning the test runs itself.
Right. Traditional hearing tests require a clinician to manually present tones and record responses. The app automates this algorithmically. It plays calibrated pure tones through standard, low-cost headphones. The student interacts directly with the smartphone, tapping the screen when they hear a sound.
How do they handle calibration? If a school in Vietnam is using a different brand of headphones than a community center in Kenya, the acoustic output is going to vary wildly, which could invalidate the screening data.
Calibration is historically the Achilles heel of app-based audiometry. The WHO framework addresses this by either recommending specific, widely available, low-cost bundled hardware that the software already recognizes, or utilizing advanced software-based calibration algorithms that can establish a baseline using the smartphone's internal microphone before the test begins.
And what about the infrastructure requirements? A rural school might not have a stable Wi-Fi connection, let alone the bandwidth to stream diagnostic data to a cloud server.
The application is designed for asynchronous offline functionality. A teacher or community health worker can conduct dozens of screenings throughout the day completely offline. The data is stored locally on the device.
And then syncs later.
Exactly. When the worker returns to a location with cellular or Wi-Fi connectivity, the app automatically syncs the de-identified data with the regional health database.
Which brings up the issue of data privacy.
Precisely. The WHO implementation considers stringent data protection protocols. In most configurations, the app relies on localized identifiers, like a random alphanumeric code assigned to a student, rather than transmitting names or birth dates to a central server. The Central Health Ministry receives the epidemiological data, like how many children failed the screening in a specific district, without violating the individual privacy of the student.
Let's ground all this data with a practical scenario. Imagine a localized health ecosystem functioning exactly as the WHO intends. We have a primary school teacher in a rural lower-income district. They notice a 9-year-old student consistently failing to engage during reading exercises and showing signs of social withdrawal during recess.
Very common presentation.
Historically, this child might be labeled as a slow learner or a behavioral problem and left behind. But under this new framework, the teacher has been trained to recognize these markers. Instead of recommending a 100-mile trip to a specialist, the teacher waits until after class, pulls out a smartphone equipped with the WHO Ears app, and plugs in a pair of standard headphones. In 10 minutes, through a simple gamified interface, the teacher establishes a baseline audiogram.
And the app flags an irregularity in the higher frequencies. The app's interface immediately triggers the referral pathway, advising the teacher to notify the local community health worker.
So the system kicks in.
Right. The health worker visits the school the next week, performs a basic otoscopic exam, and rules out impacted wax or a middle ear infection. The data confirms a likely sensorineural issue. Only then is the family directed to the regional hospital, bringing with them a digitized, objective record of the screening.
And the hospital fits the child with a robust, locally serviceable hearing aid. And the school implements an inexpensive induction loop system in the child's primary classroom.
The child's trajectory is completely altered. The cognitive load of trying to hear is lifted, allowing their neuroplasticity to focus on language acquisition and executive function. Their economic future is fundamentally protected. And it all started because a teacher had a free piece of diagnostic software in their pocket. What stands out to you?
When you analyze the mechanics of the WHO's app and the WHO's tiered triage system, the genius isn't in a new medical breakthrough. It's in the democratization of access.
The democratization of access is the defining characteristic of modern global health strategy. Dr. Chadha notes in her closing remarks that with these practical and affordable solutions now available, no child should be left behind due to unaddressed ear and hearing problems.
It's a powerful statement.
It is. When you lower the barrier to diagnostics down to the cost of a free app and a brief teacher training module, the 80% care gap we discussed at the beginning of this deep dive transforms from an insurmountable tragedy into a highly solvable logistical puzzle.
It changes the math of global health entirely. To summarize our deep dive today, we are looking at a profound global barrier where nearly 100 million children and adolescents are experiencing developmental, educational, and economic suppression due to unaddressed hearing loss.
A massive silent crisis.
But the World Health Organization's March 2026 update proves that the solution is not to build thousands of expensive specialized audiology clinics. The solution is moving the front line of care from the clinic to the classroom. By empowering educators with clear implementation handbooks, establishing tiered community referral pathways, and deploying asynchronous, offline-capable diagnostic technology like the WHO Ears app, the vast majority of these cases can be managed locally and effectively.
As we wrap up our analysis of this strategy, here is a provocative thought to consider.
Okay, let's hear it.
If a meticulously designed software application like WHO Ears can effectively decentralize hearing screenings, moving complex diagnostics from the soundproof booth of a hospital straight into a rural classroom, what other global health bottlenecks could be fundamentally dismantled by putting validated diagnostic technology directly into the pockets of community members? We are entering an era where the smartphone is becoming the most potent primary care tool on the planet.
That is a phenomenal concept to mull over. The power of decentralizing healthcare right into our pockets, changing the trajectory of millions of lives through accessible code. Thank you so much for joining us on this deep dive. We hope our analysis of the WHO's strategic update provided you with some deep insights into the future of global health logistics and technological intervention. Keep questioning the systems around you, keep exploring those everyday solutions, and we will catch you on the next deep dive.